Welcome to the TheOncoPT Podcast, where you'll learn from oncology experts, practitioners, and patients to help you on your journey to become a confident and competent OncoPT. Here's your host, Elise Cantu.
Hey, OncoPT, and welcome to this episode of the OncoPT Podcast. We are now at the top 2 episode, the second most popular episode of the OncoPT Podcast in 2024. Now, recap, if you haven't been following us along over the month of December, we have been celebrating the 6th birthday of the OncoPT, which is so wild. And we've also been using this time to count down the most popular episodes of the OncoPT Podcast in 2024. So this week we are covering number 2, and this episode, y'all, is one absolutely for the books. It is definitely the second most popular for a really, really good reason. Now, if you attended the Cancer Rehab Community Conference 2024, you actually saw this person present. And for good reason. And the reason that this person keeps getting asked to come on the podcast, to present, to talk on the radio. First of all, this person talks on NPR like all the time about cancer rehab, which I'm obsessed with, is because this is one of those impairments that we hear about a lot. And you may have a similar experience to me. When I first started in OncoPT, and even up until a couple years ago, it was kind of, well, we know this is happening. We know why this happens. We don't really have super great ways that we're treating this. And that is simply unacceptable in OncoPT, especially for our patients who are dealing with chemotherapy-induced peripheral neuropathy. That's right. We're talking about CIPN. And if you know that CIPN is basically synonymous with our amazing guest today, Dr. Katie Schmitt. Now, Dr. Katie Schmitt has an absolutely masterful grasp on CIPN and is really revolutionizing how we're treating CIPN with this protocol that she has been pioneering over the past few years. Now, she has a lot of resources available that I will be including in the show notes for this episode, but I would also encourage you, Katie is one of the most prolific commenters and posters and frankly collaborators within our free online community called the Cancer Rehab Community. So I would really encourage you after this episode, or maybe before you even start this episode, head on over to the link in your podcast player or in the show notes, and I want you to join, if you haven't already, our free online community, the Cancer Rehab Community. Katie and so many others that you know and love from the podcast and our conference that we just did are in there all the time, commenting, posting, and sharing experiences to overall make us, you and me and everyone else out there, a better OncoPT for our patients. So anyways, that's my quick plug for this episode. Let's actually dive into the goodness that Dr. Katie Schmitt has to share with us today, because she actually goes step by step through this protocol that me and so many others have been implementing in our practice, and I know you are going to love as well. So stay tuned and enjoy my interview with Dr. Katie Schmitt, the master of CIPN. Katie, welcome to the OncoPT Podcast.
Thank you so much. Thank you for having me. I am so excited to be here to talk about neuropathy. This is my favorite thing to talk about, and I'm so excited to talk to you about neuropathy because I have learned so much from your podcast, so I'm so excited to share with others about my favorite topic.
Okay, you and I both like neuropathy, but if I love neuropathy this much, you love neuropathy like off the charts this much. And I'm really excited because, like I mentioned at the top of this episode, we haven't really dove into CIPN and how it really affects our patients within cancer world, right? A lot of listeners right now have heard the term CIPN. They understand, like, yes, chemotherapy causes peripheral neuropathy. Maybe they understand a little bit about it. But for a long time, I was kind of skirting by with some absolute basics and then was just kind of fumbling through things as we go. So I would love to know, before we get into too far, first of all, why are you so excited about CIPN? How did you get into this excitement and passion specifically for CIPN within cancer rehab?
Sure. So I had another career before this. I was an actor. I traveled the country, did a bunch of different stuff, and then I decided I didn't want to live in my car anymore. and I would go back to school. And I decided to go back to school for PT. And originally it's because I was a dancer. So I had PT and I thought, great, PT's magic. I'd love to know how to do this. And throughout studying, I was learning more and more about the diaphragm and balance and cancer and breathing. And cancer has affected my family in many different ways. So I thought, all right, maybe this is my way to kind of fight cancer. And through I think my fourth clinical affiliation is where it really started to click. And so I was working with the amazing, this woman, Karen. She runs Fusion Arts out in LA. She's fantastic with dancers and performers. And we were working on ballerinas. And it just so happened that we met the woman who runs WeSpark, which is a non-for-profit cancer organization in California. And she said, well, what do you know about neuropathy? What do you know about balance? And I was talking about breathing and the diaphragm. And we decided, instead of my clinical affiliation, instead of my, you have to do a one-off presentation. Hey, my boss, this is my presentation on my thing. We would do a 4-week workshop on neuropathy and breathing and balance for all the patients. And so we came up with this 45-minute long thing, and we did some training stuff, and we ended with the neuropathy massage that I've been working on since I was a student. And the first week, patients would come back and they'd be like, I felt different. I feel different in my feet. Like, this is phenomenal. So we got to do it for 4 weeks, and patients were telling me they were feeling a difference. So I said, all right, there's something to this. And I kind of took what I was learning with working with ballerinas, with Morton's neuroma, with plantar fasciitis, and sort of turned that, combined it with the information you learn about diabetic neuropathy to kind of come up with this technique. So then I graduated, and I was working in New York for about a month, maybe 2. And my husband, who was Mr. New York for the longest time, lost it and said, nope, that's it. I'm over it. I want to be in South Carolina. I want to be with my brother. I want to be with my family. So we made the move down to Charleston. And I started out as in a bunch of different clinics and offices, but I was talking about neuropathy. And so I started talking to one of the neuro-oncologists at Hollings Cancer Center, which is part of the Medical University of South Carolina. I was like, I can really help your patients. We can do something about this. So I started treating them, but I wasn't working for MUSC at the time. So I started as a PRN PT on the weekends, and then made the transition to being there full time. And then during COVID, I have an amazing boss, and I said, why don't we have PT at the Cancer Center? This is dumb. And he said, yeah, I agree. So we came up with bullet points and figured out how to pitch it as a business and show, this is the business of treating the side effects of the treatment that we're giving these patients. We're really good at treating the cancer. We're not good at treating the side effects. So weaseled my way in the door, was working 1 day a week, spread it to 2 days a week, then 5 days a week. And now we are a full-time practice at the Cancer Hospital, which is fabulous. And in the meantime, I've been able to really study neuropathy and how it helps our patients, and helps our patients with neuro issues, with hematological cancers, with breast cancer, even some patients with idiopathic neuropathy. And it's really wildly successful, and it's simple. So my goal is to come out here and say, all right, here's a protocol that I think we can all follow, kind of like we'd follow a rotator cuff protocol. We can help fix someone's neuropathy. I've seen the changes. Usually it takes about 8 to 11 weeks. The patients are getting on board. The oncologists are getting on board. And it's just so lovely to not be able to say, or to be able to say, instead of gabapentin, here's PT. And let's see if this can help fix it. And this is why I'm so excited about it. That was my long-winded answer of where I came from and where I am now.
First of all, I really like all of the bullet points that you hit with that answer, because it brings up actually my first question, which I did not prep you for. You mentioned during your, how did I get here? Neuromassage that you learned in PT school. Did I hear that correctly?
So, the massage stuff came from working with a lot of dancers and working on Morton's neuroma, plantar fasciitis, working in between the toes, working with ballerinas. Because they just have the craziest feet. And then applying that to the research from diabetic neuropathy. And there's a great study that came out, it might have been in 2018, about Thai foot massage and how you apply that for neuropathy. And it works. It's fabulous.
first of all, that's really, really cool. I love that. I love how much that you took your background and your experience in like the performing arts and then working very intensely with this dance, these dancers, this group of dancers, to then apply that into oncology. And sometimes, Katie, I feel like this is a whole other episode brewing that we are not going to get into, because obviously we have you here for CIPN and I don't want to monopolize your time. But I feel like this is such a great example of taking all of the different areas of PT, because we know that while OncoPT is a thing, right? We know that OncoPT is, we work with patients who have cancer or who have had cancer. Right now I'm actually working with a former Rockette in my practice, and I have encountered her through oncology. But what she's dealing with now, I think, are actually some like very long-standing issues as a result of her career in dance. Anyways, we're gonna have to put a pin in that, because we could, I'm sure, chat about that all day long, because I have questions. But I love that you took this very, very focused experience with dancers and are now being able to apply, this is what we show is working. How can we take this and really marry it to some of the research that is available in CIPN? And I know there's some good research that has been out, that is coming out about CIPN, but a lot of what really informs our practice, including even for the oncology specialist certification exam, I would say like half of that literature is actually like diabetic neuropathy and other kinds of neuropathy. So how do you, like, as a practicing clinician, you've been working with CIPN for a few years, how do you kind of take these different areas where neuropathy affects different patient populations, and we know that the research, again, like, is really prevalent when it comes to diabetic neuropathy. How are you taking that and then marrying that into your OncoPT practice with oncology patients?
So I think that kind of goes to what we all do as OncoPTs, is you take what you've learned in ortho, what you've learned in neuro, what you've learned in peds, and then you have to apply it all to the patient that's sitting in front of you. And none of this stuff happens in a vacuum. So you're like, okay, let me throw everything at you. Kind of like my patient with axillary web syndrome and rotator cuff issues, and range of motion for picking up her child. So you throw everything together. I think it happened because where I went to school, I went to Columbia, and they're very big on, let's get a bunch of research, let's make sure it's all current research. And so I fell into this very jargony article about neuropathy and why it happens. And it's definitely, if you need a nap, it's a really good article to read before for falling asleep. But it really goes into, okay, why does neuropathy happen? And it's kind of, there's a neuroinflammation that's happening on the nerves, and it's kind of like we're copper wires wrapped in plastic, and the plastic gets messed up. And then it also affects your ion channels, and it affects the way the muscles fire. And so that's why you start to lose some of your strength. And it can happen because of the traditional chemo that we see, like the cisplatin, the taxanes. It can happen because of the new stuff like Keytruda that's not supposed to have a lot of side effects, but it really does. It can happen because of multiple myeloma, which attacks the cells themselves. And sometimes, I don't have the research for this yet, but sometimes patients with breast cancer will come to me and say, hey, I felt this neuropathy coming on when I got diagnosed or before I started treatment. Like, it's really super fascinating. But taking that information, right? Taking that information and saying, okay, I know how to play with a nerve. I learned that in neuro. I know how to play with a muscle. I learned that with resistance bands training in ortho. And then I can come together and I can apply this stuff to the patients I see in front of me.
Okay, I'm really excited now, and I know I'm getting ahead of myself. So let's take a couple steps back. For the listener who's brand new, what is CIPN?
The traditional definition, I guess, you would give like your first patient sitting in front of you. It is a dose-dependent neuropathy that happens bilaterally. It usually happens to the hands and the feet. It comes on like a stocking or a glove. So it starts at the toes or the fingers, usually goes up to the forearm or the knee, and then it gets better kind of the same way. All this stuff gets better first. It lingers in the toes and the fingers, and then it gets better. According to the literature, it can happen at the first treatment session, or it can happen 6 months after chemo is finished. So you thought you were good, you're walking around, you're doing great, bam, neuropathy. It is something that's supposed to go away, but usually on its own, it doesn't really do a good job of going away. And so patients come in and they have 10 out of 10 complaints, and it's not pain. This is a conversation I've had with patients many times. If you call it pain, they're going to get mad at you. It's numbness, it's tingling, it's burning, it's feeling of cold, like something is in your shoe, like you're walking on rocks, and it throws off people's balance, and it throws off their quality of life.
One of the misnomers, I think, and you briefly touched on this already, I think CIPN, chemotherapy-induced peripheral neuropathy, is a little bit of a misnomer now that we understand more about oncology kind of in general. So we know some chemos can cause CIPN. Can we revisit some of those other contributors to CIPN in addition to chemotherapy?
Yeah, definitely. I think what's really important to kind of tease out, and an interesting point is, I don't know if we're teasing it out because we're trying to talk about all the different people that we can treat, or because we're trying to figure out more about the why this causes the neuropathy. Because it's interesting, the different why you have neuropathy, we kind of treat the same way, which is interesting. But that's my whole other, like, I'll dive into that research down the road. So talking about, yes, we have the chemotherapy-induced peripheral neuropathy. You have your patients with diabetic neuropathy, and you may have patients who have cancer and diabetes, and you don't quite know why they have the neuropathy, but you know it's there. You can have neuropathy from multiple myeloma. It's one of the hematological cancers, and one of the side effects of multiple myeloma is that it goes and it destroys the myelin along the nerves. So that can be an issue as well. And then we also find our idiopathic neuropathy. So someone comes in, they said, I don't really know why I have it. You kind of have to tease it out. Is it like a demyelinating thing? Are they running up against like a Guillain-Barré or a myasthenia gravis, or is it just something that's sort of floating in their past medical history all by itself? Yeah.
You're already, Kate, like we've been in this conversation like 15 minutes already. You're already making me think back to previous patients that I've seen. So I've seen a patient who was on Keytruda previously, had a pre-existing nerve injury that just seemed to be getting worse. And genuinely, like, this is the first time I'm really reflecting on that and thinking, like, I bet she had a little bit of CIPN that was starting to manifest, potentially because of the Keytruda. Maybe it was a different agent that I'm forgetting. But also, I've had a couple patients with multiple myeloma now that I'm thinking, I don't think I was screening for that because I didn't think that their chemotherapies were going to lead to CIPN.
Because you're talking about like Revlimid or immune therapy. Yeah, you're not always talking about like Velcade for sure. That's one of the ones that's going to cause it. But yeah, thinking about all the immune therapies and you're thinking, okay, this is supposed to be much different. But I think, and especially with the blood cancers, and I could be wrong. So if you have a listener who's like, nope, this is wrong, just let me know. It's a systemic treatment. So we're treating the whole body. And then the chemo pools in the fingertips and it pools in the feet just because of gravity. And so that's creating some of these sort of pooling side effects.
Can we talk big picture here? Like, very zoom out. What happens to make CIPN happen? Like, what physiologically takes place that causes a person to have this damage or injury to their peripheral nerves?
Sure. So the jargon of it is it causes the neuropathy or the chemotherapy, the way that it attacks the cells and the way that it attacks the different cell cycle for where it's trying to fight the cancer, causes a neuroinflammation. It also causes a swelling of the mitochondria, so they're not firing properly, they're not doing their job properly. It messes with your voltage-gated ion channels, so think about that drawing that you used to draw in physiology when you were trying to get into PT school in the first place. Your calcium and your sodium, they're not firing properly. So I go back to sort of that copper wires wrapped in plastic. Your plastic has been destroyed. And then it's kind of like you're a flashlight also, and your battery is loose. So you have this sort of muscle twitch and muscle clonus.
Yes.
And that's caused from the chemotherapy itself. And then you can certainly I'll give you the link for sure. This article, you can dig into, okay, my patient is on this type of drug. What does that mean? When I did the CSM 2023, I got to present about neuropathy, and I hope everybody stayed awake for the first 15 minutes. That's when we talked about, okay, taxanes do this, and apothalones do this, and immunotherapy does this. And it's very interesting because they all have different rates of CIPN. And when you look at like the APTA fact sheet for treating CIPN, they rank it about 68% of a side effect for what your patients are going to see if they've been on chemotherapy. And there's so many different levels within there for what we might expect our patients to have if they're on chemotherapy. Yep. And again, another topic for a different podcast, but I've started to talk to one of the heads of the hospital where I work and seeing, okay, we know that this is a side effect. We know that our patients are going to get this. If you're going to put someone on a platinum drug, can they see me first? Can I treat this first? Right? Can we decrease the likelihood that they're going to get the neuropathy, or can we decrease the severity of the neuropathy so that they can go through their entire chemo regimen and you don't have to stop it because they're having these symptoms? So
bingo. Really
cool stuff that I'm sure I'm not the only one doing. There's probably a lot of great people out there studying this right now, but following that sort of prospective surveillance model that Nicole Stout put into place, she's amazing. How do we treat all along the lines if we know we're going to cause this stuff for patients?
Katie, I can tell that you've already prepared for the oncology specialty certification exam, because the way you're just linking everything together and all these different hot topics, because I'm always thinking about how can I make that preparation a little easier, and you just flow so easily from all of those different topics. I mean, chef's kiss, perfection. So that's so many different ways that we could take this. Let me kind of rein in my thoughts here. CIPN is obviously very bothersome for our patients, but one of the things that sometimes flies under the radar is it's actually it can limit significantly the dosage that patients are receiving. And whether or not we like to think about this has potentially significant ramifications on their long-term survival, And so that is something this is not just a little numbness and tingling in the fingertips and the toes. This is very bothersome for patients, but potentially can alter the treatment plan that they're on, and that absolutely is way bigger than I think we give it credit for.
I just had a patient the other day, and she's phenomenal. She wrote back to her oncologist and she said, you know what, I've been dealing with this neuropathy for 2 years. I've been going to other places. I'm going to see Katie now. It's making a difference. And I have to say, I wish you told me that this would be such a big side effect up front. I don't know if I would have changed my cancer treatment, but I really would have liked to know about it.
Yes.
And it's so important that we take that position, because if we can decrease those symptoms, you can get people through the full treatment and the full dosage, and you can follow the NCCN guidelines a lot better than someone who's saying, you know what, I'm on my 4th episode of cisplatin. I can't feel my feet. I can't move around my house. I'm out. I'm done.
Right.
We need to give them another option.
And if we're going to catastrophize a little bit, I know we already talked about the potential survivorship ramifications of this, but if, a lot of my patients, and I'm sure this is the same for you, Katie, a lot of my patients are older and they are already at risk of falling. And then you throw in CIPN on top of this. I mean, this is a recipe for a fall, and especially that is the hospital is the last place that we want these patients. And that is potentially if they have a fall and they injure themselves, they may not be going home. And this is something this is very much on my mind, because my grandmother, 2 years ago, had a fall, broke her hip, and that was the catalyst. She is no longer safe to live on her own. She is now in a facility. And that is something that absolutely is of concern to patients. And maybe if it's not of concern to that patient, it should be our concern, but it's definitely the concern of their spouses, their caregivers, their family members, who ultimately have to pick up the pieces of this, it's just a little numbness and tingling. No, it's not, right?
Right. And if you fall, and you're in the middle of chemotherapy and you fall and you have to go to subacute rehab or acute rehab, you can't get chemotherapy. So your treatment's been delayed because you're trying to walk again, where we could maybe have done something about this earlier on. I do have to like a shout out. There's a wonderful hemoncologist that I work with, and he's starting to tug test people before he puts people on chemo.
Oh my God.
It's amazing.
Oh my God.
And he's like, okay, you scored worse than a 12.5. That's it. Go to PT before we start you on chemo or your stem cell transplant. Like, this is phenomenal.
Oh my God. Gives me such happy little butterflies. Like, this is what we've been working for.
Yeah.
I don't think I can beat around the bush any longer, Katie. Like, let's dive in. What can we actually do for the patient who has CIPN? I mean, like, we've talked about what it is. What do we do about it, right?
Yeah. Yes. This is my favorite part. And I'm giddy when I talk about this stuff. And I'm giddy when my patient sits in front of me. And they come into the office and they say, all right, I have all these things. And you're like, yep, I've heard it. And they say, I have 10 on 10 pain and I can't do anything. And I get really excited. And my students now get really excited. And we're like, this is it. We're going to fix this. So through looking at what the APTA has put out about neuropathy, through looking at all the research, through looking at like working with dancers and doing this for the past 5 years, I have kind of come up with a protocol that I would like to suggest for everyone. So day 1, you do your eval. You say, all right, I'm going to teach you a little bit about why neuropathy happens. I'm going to give you the explanation about the copper wires. I'm going to teach you about the flashlight, telling people so they understand. They go, okay, yeah, this makes sense now. I'm not crazy. I understand this. And then getting into, I think the manual therapy part of treating neuropathy is the biggest part. Yes, we're going to get into balance. We're going to get into TheraBand exercises. We're going to have a walking program. But if you had Morton's neuroma or you had plantar fasciitis, we'd touch your foot. So you came to me, I'm a PT, I'm going to touch your foot. And I'm going to get my patients to touch their foot, and I'm going to get their significant other to touch their foot. Mm-hmm. And what I tell everyone, because the significant other looks at me and they're like, I don't like feet. I'm like, okay, here's the deal. You rub the foot of your loved one, and when they get better, they're going to rub your back. That kind of wins people over.
Oh, nice. Very nice.
a little bit of bribery. So thinking about the foot and thinking about what you're going to do, here's my secrets. And I would love for everyone to take this and run with it and use it for their patient tomorrow. There's a video on my website. There's a video on the website of the hospital that I work with. You can totally use this. So you're going to take the foot and you're going to start with the heel and you're going to massage the fat pad. And then you're going to follow the Thai foot massage guidelines and you're going to massage through to each foot. And then you're going to expand the ball of the foot, because your patients have probably said, it feels constricted, it feels tight, it feels like something's holding on to my foot. So you're going to take the ball and you're going to spread it out. And then you're going to play with the toes, because the toes are probably tingly, they're probably cold. The first time you do this on someone, you're going to have to go light, but not too light that it's ticklish. Otherwise, they're going to hate you, and eventually they're going to love you. And then you get into the top of the foot. And this is where I think it's the secret to treating neuropathy. Kind of like you would treat your Morton's neuroma. You're going in between the big toe and the second toe, and you're going down in between those metatarsals. And you're looking for the trigger points that are in between those feather-shaped muscles. And you're trying to find your trigger point, hold on to it, give it 30 to 90 seconds, tell your patient to breathe. They're looking at you, their eyebrows are very high. You get them to relax, you get the trigger point to relax, and then you move on. And then you joint mob all those metatarsals, because you're thinking, okay, these 3 feet or these 3 toes work differently than these toes. If you think about your prosthetic and how prosthetics are made, so you're hinging these guys, you're kind of going back and forth on these 2. You pop the toes, push the swelling back over that talus curl joint, up to the lymph nodes behind the knee. Done. That's their massage. I'm so excited. And that's what they're going to work on. The patients that I have who are having the best results with this are doing this 2 to 3 times a day. Yes, it's a lot, but do it after breakfast, after lunch, after dinner.
Right. I
tell my patients to do it 3 times a day. If they come back to me a week later and they're like, yeah, I did it once a day. I'm like, great. Fabulous. I'm happy with that. Week 2, now I have to preface this. I see patients only once a week because I'm the only one that works in my department. So I need to get in like 50 patients a week. And when I first started treating, I was treating during COVID. So I didn't want to bring a lot of immune compromised folks into a space, make them come down, make them show up. So we decided once a week, if people are good with their homework, will work. And it actually really does, which is awesome. And I've had some patients where I've never met them in person. We've done the whole thing over telehealth and they get better too, which is really cool.
Oh my God.
Right? It's so cool. And it's all about like getting your patient to do their homework, which it doesn't matter what branch of PT you work in. That's what it's all about anyway. So the massage, and I have a video on my website. Like I said, there's a video on the hospital's website. So making it easy for the patient to follow along with. And then the second week, we're going to think about those ion channels, and we're going to add in an ankle exercise. So we do, if you've ever sprained your ankle, you might have done the ankle 4-way where you take a TheraBand and you're going dorsiflexion, plantar flexion, inversion, eversion. Yep. So we're working them through that exercise. And then we're adding a gastroc stretch, a soleus stretch, a fascia stretch, thinking, okay, that's all connected all the way down the chain. How do I stretch out the back of the leg? And then week 3, we're starting to add on some balance stuff. So you've got your tandem stance, you've got your single leg stance, add some head turns, add some eyes closed. And then as you progress your patient, you're thinking, okay, what do you want to do? Do you want to do yoga? Are you a rockette? Do you need to go back to a kick line? Do you want to play pickleball? It's a big thing in Charleston. It's probably
big here too. Yep.
Sweeping the country. Do you want to play pickleball? So let's get you back to that stuff that you want to do. And meanwhile, still reminding you, do the massage every day, do your ankle exercise, do your stretches, do your walking, and you're kind of combining everything that is on that really nice fact sheet from the APTA, aerobics, strength, balance, and we're adding in the missing piece of get in between the metatarsals of the foot, and then we can help get rid of that neuropathy. And that's it. You're ready. Go treat patients.
I know you said, like, you were giddy about this. Like, I'm giddy about this. Like, I don't know if you could see my eyes just getting bigger as you talk through that. That is so exciting. And I think this is the first time I've really had someone sit down with me and explain all the way through, not just like, here are the agents that cause CIPN, but what does it physiologically do at that cellular level? And then, and then tying those interventions directly back to what is happening. Oh my gosh, Katie, I have chills right now. This is so exciting.
It's so exciting. Like, thank you for sharing. It's so exciting. And with the neuropathy, that's how I was able to convince the neuro-oncologist. And that's how I was able to convince my boss. And that's how I'm able to convince the people at the cancer center who are probably like, yeah, I can do this exactly. So I've talked with this oncologist. He knows I'm going to share this story. One of the heads of the department, usually they give out gabapentin. They're like, I don't know, take some gabapentin, good luck, goodbye. So I'm very loud about neuropathy, and I keep talking about it. And so one of the heads of the department had a patient, and he was a patient with GI and lung cancer, and the patient's like, I have neuropathy. I can't get back on my bike. I can't do anything. I need to walk around. And so the oncologist says, I don't know. There's this girl. She thinks she can do something. She says she can fix neuropathy. I don't know. Give it a shot. So the patient comes in and he tells me that this is what the oncologist has said. And I say, all right, great. This is my chance to really prove the point. And now the patient has been doing fantastic. He's going to be one of the stories in our newsletter. He has convinced the director of the hospital that this is very, very important. And they have said, all right, let's do more research on this. And let's see, I'm going to prescribe cisplatin for a lot of my patients. Yeah, let's start thinking about doing trials for PT before, after, during. And it's amazing because it's so simple. Like I was able to talk you through, like, how do we treat neuropathy in maybe 3 minutes.
Right.
And that's what makes me so excited about it, is it can be a protocol that's just as simple as like rotator cuff. Here you go. And then just apply it to whoever's in front of you to make it special for them. And then you said, all right, wherever you are, whatever cancer hospital you were treated at, they probably do a really good job of treating the cancer. and you're here and you're feeling good. And sorry, you're here and you're feeling. Now we want you to be feeling good.
Yep.
So now come to PT, come to OT, come to speech. Let us deal with all the side effects and get you back to being you. And that's what it's all about.
Oh my God. I like, you have channeled your giddiness through the computer, and I'm over here just like basking in the excitement. If you are, so in the case of, you now have oncologists who are really embracing this of, wow, this is really working. What can we do to get ahead of this? Because again, we already talked about in this interview that neuropathy can be a dose-limiting side effect. How would you take this program that you just very briefly walked us through? How would you then adjust that for like a true prehab situation where you are really getting a patient who, let's say they're going to be on cisplatin or, you know, any of these other neurotoxic agents, and they're at risk of CIPN, but they don't have anything yet, and they haven't started treatment yet?
So my goal eventually, we all have these big goals for what we want to do with oncology PT, is that as soon as you get your diagnosis, you get a referral to PT.
Yes.
You see us, we can say, all right, this is what they have planned for you. This is what I think you might run up against. Let me take your baseline. Let me do all this stuff. That's my ideal world. Again, I work in a clinic all by myself. So it's not really happening anytime soon where I get every single patient with neuropathy.
Yep.
So I work at MUSC, I work at Hollings Cancer Center, which is part of MUSC in Charleston, and we have an amazing media team. And so they have listened to me as I'm saying, all right, we need to do this video and that video and this other video, because part of it is you're going to go on chemotherapy. There's going to be a bunch of steroids in there. You're going to go through your nadir period. You're going to crash. And then 2 days later, you're going to be awake at 3 a.m. going, all right, what do I do now? So at 3 a.m, you're going to go on the Hollings website and you're going to pick from our myriad of videos, and you're going to do a stretching video, or you're going to do a neuropathy video, or you're going to do an ankle four-way video. And that's what we're doing right now, is to educate the nurses on the infusion side and the folks that are with these patients right now, who are saying, all right, how are you doing today? We're going to hook you up. You're going to be here for 3 hours. Oh, you're talking about neuropathy? Okay, well, here's a pamphlet that we have that's going to tell you a little bit about neuropathy. Here's a video. Go follow it along. And then if you feel like you need more PT, let's get you into PT. And it's been really nice that some of the providers have seen these videos, and I have a radiation oncologist who's just phenomenal, and she's done all these great programs for patients. But she'll walk down the hallway and watch people kind of limp or have their antalgic gait down the hallway, and she'll be like, I don't treat you, but do you have neuropathy? Okay, great, you're going to go to PT. So I guess it's about what can everyone do right now is just be loud. Be loud to the folks who run your institution. Be loud to the neurologists in your area. Be loud to the oncologists in your area and say, hey, we can do this. We're PTs. This is within our scope of practice. Patients can have this covered by their insurance, and it can help your outcomes be better and be stronger. And a lot of the NCI designated institutions are saying, well, how do I have better outcomes? Because I want to rise in the ranks of being an NCI designated place. So if you can say, hey, I can help, that's a huge thing. And again, this is, yes, I get to do this right now with a cancer hospital, but I started at a regular outpatient orthopedic clinic and started getting their attention this way. And I think sometimes people are afraid to approach the surgeons or the oncologists because they think they're really busy. They're not going to listen. And yeah, they're super busy, but they'll listen and they'll be really excited. And I've had oncologists who write me back, head and neck surgeons, and they're writing me back at midnight after they finish their surgery. And they're like, thanks for seeing my patient. I'm like, this is great. So they're just people, just like us. Just be loud about how we can help.
And I really love the story that you led with all of this is your patient was the one who ultimately went back and was such an advocate for your services, whether or not they intended to be, but just them sharing their experience of, look at how far I've come, look at what I'm now able to do. Physicians listen to that. I mean, if I and I think that's sometimes, especially as new grads or like newer to oncology, we very much have that mindset of like, oh, oncologists are busy, like they probably don't have time for me. Maybe not. It's always worth a try. But one of my best ways that I have found to get in with an oncologist is if I have a patient who gets me in the door first by like, hey, I went to PT and I saw Elise or I saw Katie and we did this thing, or like, now I'm feeling so much better. Like, look at what I went and did. Like, I went and got to hold my grandbaby for the first time.
100%, you're right.
Oh my God. Oh
yeah,
my God.
if you can get the patient to advocate for you, yeah, that's hands down way better advertising.
Oh my God. Okay, so when is the CPG coming out on chemotherapy-induced peripheral neuropathy? Because I need to get my hands on it, Katie. Like, let's go.
So I just became a board certified oncology PT this year. Thank you. And thank you for your help for getting ready for that test.
You're welcome.
I just did my first CSM this year, so I'm kind of getting to know everyone, and everyone in the oncology community is phenomenal. There's so many people, and I feel like I'm giving my Emmy speech, just trying to thank everybody. So whoever can point me in the right direction of how we come up with another, there is the fact sheet, and the fact sheet kind of puts you in the right step. But there's so much more that we need to do, especially because right now for even thinking about like your functional outcome measure, when you're going to give a patient, insurance really likes you to say, here's your form, fill it out. There really is no good form for neuropathy right now, unless you have breast cancer, and then you can use the FACT GOG, but it's not, I don't love it, but it's what we have. So whoever can point me in the right direction of saying, yeah, let's revamp what we have and let's put this out here. And I'm very excited to do a virtual class for the APTA where we dive deeper into this and talk more, and we'll all do the massage together and we'll all do the ankle exercises together. And I'm really excited. I have been trying for the past 3 years to get this published. So we have a case study of 2 patients with multiple myeloma, and then we turned it into a study of 26 patients with different cancer types. And then we decreased it back down to a study of just 17 patients with multiple myeloma. And unlike the other Katie Schmitt, I cannot seem to get published to save my butt. But I can talk about all this stuff. So if anyone is really good at getting published, let me know.
Call us up, y'all. Kate, we need to get this Katie published. So I'm just so thrilled, Katie, at how easily you made it all seem to like have a very strategic, implementable process for treating this. Because one of the things that and this was several years ago, like we may have literally learned more information since it was first communicated to me. But I remember like when I was first working with patients in my student clinical internship, the conversation around CIPN was very much like, well, this is what we're trying. This is what seems to be working for about 50% of our patients. And like, if it doesn't work, then we're kind of out of options. And it was very much, it's so exciting to now in 2023 be having this conversation about these are some strategies that are now working better, that are better informed because of research. We're also seeing this work very well clinically, and I will definitely be implementing this ASAP in my own practice. It's just so exciting that over the past 5 years of my practice, I've been able to see these changes for the better of really actually being able to show up and treat patients and not just have this like, well, we hope it works.
Yeah.
If not, sorry.
That's always the thing that's really scary as a PT and as a new PT and as a new PT in a specialty. And I always I remind myself when I was in, I think it was my 3rd clinical, and I was treating a patient with sciatic nerve pain. And you're like, okay, just trust me. Give me a few more weeks, because I know that I've read the literature that says if I dry needle you here and if we do some clamshells and if I work on your glute med, it's going to get better. And that's one of the things that I can now confidently say to my patients is I say, all right, the first week you're going to feel something. You're going to be like, yeah, all right, my feet feel a little bit different. Weeks 2, 3, 4, you're going to be like, I don't know. Is she right? I can't trust this girl. Stick with it. Week 5, week 6, week 7, that's when you're starting to walk more. That's when you're starting to go out and do the things that you want to do. That's when the sheets don't bother your feet at night. And so I think coming together as an oncology PT community and saying, all right, let's try this and let's Let's try this in Colorado, and let's try it in Texas, and let's try it in Carolina, and let's try it in New York, and then all coming together and saying, hey, we're of the mindset that this is working. And if someone's out there and they're saying, you know what, I went to CSM and I do this already and it's great, and then I also added stereognosis where I draw letters on my patient's foot, and that's really helpful, we can just make it stronger and stronger. And then that gives you the confidence to say, yeah, trust us, we're this big hive mind of oncology PTs, and we know that this works, not because we want it to work and not because we just think it's really cool, but because we have the proof.
What kind of advice or what key points would you encourage newer OncoPTs to include within their treatment plan for a patient with CIPN? We kind of talked through, like, here's your week by week step. What are maybe some things that, like, we tend to forget or we accidentally don't include in our plan that we should?
Yeah. I know that looking at all the research, I'm bad at reminding patients to have the aerobic part of it. I get about 40 minutes with my patients. I'm spending a good 23 minutes on the manual therapy part of it. But tap into what your patient likes to do as far as, is it a walking program? Is it a cycling program? Is it, do they like to, I don't know, roller skate? Or are you dealing with a lot of cancer-related fatigue on top of the neuropathy, and you're thinking, okay, I have a patient who's really deconditioned, they've been through some stuff, how do I also have an aerobic portion? Teach them about the 6-minute walk test, make them do it around their kitchen island. And tapping into knowing what your, I guess what your limitations are in your clinic, and then seeing what kind of patient you have so that you can say, all right, I really want to do, I know that it's manual, it's a TheraBand exercise, it's balance, it's stretching, it's aerobics. I really want to do this because I'm good at it and I can help my patient with it. And then I'm going to lean into my patient to do some of this other stuff. And I'm going to lean into the caregiver. Because I find in the cancer setting, like, patients have had this trauma thrust upon them and they don't get to decide a lot of stuff. Like, you're going to do this drug, now you're going to do this, now you're going to do this. So you can come to them, and I really learned this a lot more with my pediatric patients. If you give your patient, you say, all right, here's everything that I want to do to treat your neuropathy. What do you feel like you're going to be really good at? What can I trust you to take charge of so that I can focus on some other stuff? And then you're giving them this sense of control over a situation they didn't have control over before. And I've had patients take that and run. Like, I had a patient who was like, every week I'm going to graph my pain at 9 o'clock and at 3 o'clock and at 6 o'clock. And we're going to come up with all these really cool ways to figure out how I'm feeling on days that I've done the neuropathy massage and on days that I've just done the stretching. Like, this is phenomenal. So tap into what your patient really likes and what you can give them control over and what part you can have them play in it. And their consistency with this just goes up. And then they start to get really good at stuff. And kind of like with the oncologist, then they're telling their neighbors and they're telling people at the supermarket, they're like, oh, hey, watch this video, we can fix your neuropathy. And it's so cool when people take it and they run with it.
Yep. So you've been talking about different resources throughout this interview. So where can people go and, like, watch those videos that you've been talking about?
Sure. So they can go to my website. It's Dr. Katie DPT, pretty easy. And there's the neuropathy massage video, and there's the ankle 4-way video. And within the next few weeks, there will be a video for the hands, because this does also work really well for the hands. And there will be the protocol. Like I said, I'm having a hard time getting this published, so I'm just going to put the protocol up on my website, and there it is. Everyone can follow it.
Love it.
There's also, I work for the Medical University of South Carolina. It's Hollings Cancer Center. My media team is fabulous. So if you look up Hollings Cancer Center Physical Therapy, you'll come up with our page, which is a big picture of me working on someone's foot. And if you scroll down to the side, there's our YouTube channel. And so there's videos for the neuropathy massage, for the ankle 4-way video, for balance, for there's videos for graft versus host disease stretching, for post-breast cancer exercises. And I think that YouTube has become such a great resource for patients. And COVID is not a good thing, but COVID was a good thing because it's taught people to be a lot more internet savvy. So even your folks who are like, oh yeah, I'm 87 and I watch TikTok all day long. Like, this is phenomenal. Great. Go do the video. And we're getting more and more great videos out there that people can trust, and it makes it easy for them to do on their own. And it makes it easy for them to do at 2 a.m. when they're like, okay, my steroids kicked in, now what?
Bingo. Oh my gosh. I will, of course, be linking to those in the show notes. Is there anything you would like to leave people with today, Katie, as we close out our interview?
I guess 2 things. First is please go rub all of your patients' feet. It definitely is going to help. If you don't like touching feet, my student has come up with, she likes to say, oh, I cut myself on vegetables, and she'll put on a pair of gloves. Or she'll have a towel on her lap. So that way she can, do it in her own way, and it doesn't make the patient feel bad. And then B, you have so many people who listen to your podcast, and it's such a great podcast. And I'm going to ask everybody out there, find what you really love. Like, I made a model of the foot when I was still a student to figure out how the Achilles tendon twists into the calcaneus. And that kind of led me down this road. Figure out what you're passionate about it, and please dive into it, be nerdy about it, and then share it with us, because we need to know what to do with all those other topics. Like, I'll talk about neuropathy all day long. Thoracic spine, rib pain, or some neck fibrosis, I'm going to turn to the research, but I need you to be excited about it and tell me what to do. Yeah.
Oh, I love that. And y'all know we're all nerds on this podcast. So, like, lean into the nerdiness, because we need more of it. This conversation was long overdue, Katie. Obviously, A, to have you on the podcast, but B, like I said, this is the first time that I've genuinely had someone sit down and talk me through the physiological changes of what happens when a person is developing CIPN, but then truly tying that into very purposeful, intentional interventions. Oh my God. Like, talk about, again, tying it back, talk about like the nerdiness leaning into that, becoming a very like feasible it's a very logical, logistic way to implement a very standardized pathway for something that bothers patients a lot and affects not only their quality of life, but potentially also life expectancy for some of the ways that we've talked about. And that's really, really important. And so it makes me very excited to think about, again, like I'm getting giddy again, to think about we have a better plan because of what you've taught us today and how we can address that for our patients to ultimately get them back to what they want to do and what they love to do. And that, that just gets me fired up. I'm just so excited about that.
Because that's the whole point. Like, you go into being an oncology PT and you want to just get someone. We all probably have someone in our families or in our lives who's had cancer, and you can see the things that they can't do anymore. And so you as the oncology PT get to say, you know what? You can do this again. And that's what it's all about.
That's my favorite part. That's my favorite part.
Yeah.
Oh my God. Katie, this was wonderful. We will definitely be having you back on the podcast. We've got, as you were talking, I've thought of 3 more interview topics to have you on, so you'll definitely be coming back, don't worry. Where can people follow you, connect with you if they want to keep this conversation going?
Yeah, definitely check out my website, Dr. Katie DPT. You can send me an email through there. It's also drkatiedpt@gmail.com. You can send me an email through there. And then I am on Instagram, but it's usually pictures of the ocean or furniture that I've made. So it's not usually neuropathy stuff, but you can find me on there too.
Well, thank you so much, Katie. I really, really appreciate your time. And again, you have such a gift for explaining things in a really, really easy to understand way, and I'm really, really grateful for that. So thank you so much for coming on here and sharing all of this wealth of information for me and my listeners.
This has been so fantastic, and again, I can talk about this all day long, and if anyone has a question, or if you're like, you know what, I went on and I looked at the video and I still can't figure out the whole metatarsal thing, shoot me an email. We'll have a conversation. We'll spend half an hour working on stuff, and that way we can all just treat people even more.
Thank you so much for listening to this episode of the TheOncoPT Podcast. If you'd like to help support the podcast, please share it with others, leave a rating and review, or support us on Patreon.